Welcome back to another high-yield general surgery shelf review video where we review types of shock in both trauma and general surgery settings. If you haven't made it over to the emergency medicine shelf review video, please click up in the right corner here. I will also have a link in the comments and the description of this video to link you over to that video where I dive into a deeper approach to the trauma patient. For now, let's get into the physiology of shock in surgery patients. The first thing you need to do in patients who you are concerned have shock is the basic ABCs, assess the airway, breathing, and circulation. The most common cause of shock in trauma in postoperative patients is due to hypovolemia. Recall that there are three things that tissue perfusion depends on. First, the cardiac output, that is the stroke volume times the heart rate. The second factor is the systemic vascular resistance, or the total resistance, which is equal to the mean arterial pressure minus the central venous pressure all over the cardiac output. And the third variable is blood pressure. Cold and clammy skin may give an indication for obstructive cardiogenic or hypovolemic shock. Bradycardia in shock states may give you a clue into neurogenic shock. There are no absolutes. Take into the complete picture the type of trauma and location of injury and injuries, perioperative period, and basic physical examination findings, including skin turgor. The two main types of hypovolemic shock are hemorrhagic with a bleed or non-hemorrhagic, no bleed. The treatment in hemorrhagic shock is very straightforward. Give the patient blood products. In non-hemorrhagic hypovolemic shock, give the patient crystalloid fluids. I prefer lactated ringers, except in special populations like neurocritical care patients who benefit from normal saline solutions. If you would like a review on fluids, the video in the top right corner is a review of fluids. In both these situations, the first organ affected in hypovolemic shock is typically the kidneys. Remember, from physiology, blood is shunted away from the constricted renal arteries, so you need to watch out for florid renal failure. Track accurate ins and outs, or I's and O's. Briefly, if you have not seen the prior wound care video, link in this description, but recall that many traumas and wounds are not clean. So in terms of septic shock related to bacteremia, your gram-negative bugs include E. coli, Klebsiella, and Pseudomonas. Gram-positive bugs include Staph aureus, Enterococcus, and Coagulase-negative staph. Here is a brief table to review the forms of shock in relation to pulmonary capillary wedge pressure, cardiac output, and systemic vascular resistance. I do briefly want to mention spinal shock, which presents with hypotension, bradycardia, sometimes absence of rectal tone. This will present primarily in trauma and cancer patients. Otherwise, here are the etiologies of shock for your review. I believe out of all of these, the hypovolemic shock is high yield for general surgery shelf review, so monitor the urine output in hypovolemic shock. Blood products are necessary for hemorrhagic shock. That concludes this video. If you have any questions, please leave a comment. Otherwise, I will post video links for your viewing in regards to fluid management and post-operative review. Thank you for your time.